All right. So today we talked about electrical storm. Dr. Edafe Emmanjuel, consultant interventional cardiologist with UPTH and with Cardio Care, will be taking us through some of the slides. Of note is a case we managed in Cardio Care recently. Myself and Dr. Edafe managed a very challenging case. We thought it wise to talk about this. Perhaps, I don't know about Dr. Edafe, but I've not seen any such case in Nigeria since I've been practicing for a while now. So it's a very important topic so that everybody can get themselves acquainted with it and,
Yes.
and then make it so. So Dr. Edafe needs no introduction in this group. Dr. Edafe is an astute physician and a fantastic all-round guy. As an all-round good guy, let me say it that way. So Dr. Edafe, over to you.
Dr. Iseko, thank you for the kind words. So today we want to thank again Pace for Life and all the good guys, AJ, Julius, Jared, for the fantastic work everybody's doing. We are going to take electrical storm today. So this is the outline. We just introduce briefly. We talk about case presentation. Just as Dr. Iseko said, we managed one case recently. Then there were two cases. I also saw one 2018, one 2019. I will just talked about them briefly as they are really challenging. Then look at the discussion of the cases, then we conclude. There is no conflict of interest to be made known in this presentation. So electrical storm referred to multiple recurrences of ventricular arrhythmia over a short period of time. In most instances, the arrhythmia is ventricular tachycardia, but it can also be polymorphic ventricular tachycardia or ventricular fibrillation that can result into electrical storm. So the arrhythmia can be self-terminating, but frequently they are to either be terminated by either antiarrhythmic medication or by reasons of defibrillation or antitachycardia pacing. In contrast to repetitive ventricular arrhythmias occurring in ventricular storm, incessant ventricular tachycardia is defined as the hemodynamically stable VT which persists longer than an hour. So the summary here is that the first case is a 56-year-old lady who has been living with diabetes for about 10 years, hypertension and dyslipidemia about 3 years. She presented to our facility at the Cardio Care Multi-Specialty Hospital with shortness of breath, chest pain. The pressure at the emergency was unrecordably low, and this is the EKG at records. So obviously the patient was having sinus rhythm and deteriorated straight into ventricular tachycardia. And this is with hemodynamically unstable. So the first thing that was done was that he was actually cardioverted with the defibrillator. Then she was given IV amiodarone. And what we did was that we planned this patient for an ICD. So on the day of the ICD, wow, we enter into a real time in the cath lab. So these are the various shocks on the day of the ICD. What did we notice on the day of the ICD? We have our puncture, very fantastic. It went on very well. There's no issue with the puncture. Then to get our ventricular leads into the right ventricle, oh my God, it was a hell to do that. Dr. Iseko has to unscrub to go and mount the direct the advanced life support protocol, because immediately the lead advanced into the right ventricle, and as it touches any part of the right ventricle, there is a VT that is generated. We use all the doses of medication available to us, especially amiodarone. We preloaded with IV amiodarone, also continue with the oral amiodarone, yet we're having it. We shocked this patient multiple times, almost 8 times during during the ICD implantation that took roughly less than an hour. So we shocked this patient almost that 8 times because anytime the lead goes in, she goes into a VF, it goes into a VT, and we choke and it return back, we shock and it return back, but we successfully positioned the lead. And after positioning the lead, we went into positioning of the atrial lead and we closed back. And then after that, the next thing is to look for, to do an angiogram. We did an angiogram for the patient and found out that even though she's diabetic for that number of years, the coronary arteries were all perfectly normal. So what is this? This is non-ischemic cardiomyopathy. That is what she has. And the ICD was in place. We move her straight to the ICU. In the ICU, we are getting some of this, some of these reports in the ICU have not sustained VT, while even on the medications. So after she spent another 4 to 5 days in the hospital before we finally discharged her, and finally she's coming to see us in the outpatient clinic, and she's doing very well. So we discharge her on amiodarone, optimal dose of amiodarone, and also bisoprolol, and continue on that. So the second patient is happened to this case happened in 2019. She had a St. Jude ICD implanted outside Nigeria, specifically in London. She returned home, and while about 8 p.m. in the evening, she started having multiple shock from the ICD, and she was rushed to the nearby hospital, and several EKG done showed that she had ventricular tachycardia, sustained ventricular tachycardia from the ICD. So that was around 8 p.m. and the city where she is from, where I live, from Port Harcourt, you have to take almost 4 hours to transit. So the plan was that they would move her as early in the morning because it's already late in the night, and the ambulance driver was not ready to take a risky movement through that would last him for almost 4 hours in the night. So, but unfortunate thing happened. She had almost 35 shock between that 8 and 2 p.m. and I was awake with the cardiologist. I instructed to give all manner of medications, and we did, or even to the point of going to the things that are not even recommended, of giving magnesium sulfate after we exhausted amiodarone, exhausted every other thing. Yet the shock continued, and the battery was drained out, and the arrhythmia still continue. As at 2 p.m., the lady still continue having this recurrent arrhythmia, and by 2:30 a.m. in the morning, she passed out. So she couldn't get to where I was before this unfortunate event happened. The third case happened here in Port Harcourt. That was 2018, a 76-year-old retired colleague of our, a very senior doctor who had who lived with diabetes, hypertension, and dyslipidemia. She had STEMI, which presented with ventricular tachycardias and cardiogenic shock. And she kept having this recurrent VT over the night. And it was around 7 p.m. that this event happened. But I happened to know about it around 10 p.m. in the night. I rushed to the hospital to see what we can do to stabilize before we can move him to the cath lab. And over the night, we did not sleep. But after episode of about 8 episodes and on amiodarones, and we have to combine amiodarone and lidocaine, the patient has some relief before we took her to the cath lab, and it was a STEMI LAD, mid-LAD total occlusion. We stented it, and after that, we have to put the patient on ICD for secondary prevention. So these are the 3 cases we have. Now, by definition of electrical storm over the years, a number of things has happened to it. Before now, we're talking about 2 episodes separated by an hour apart, but the most recent definition now talk about 3 episodes in 24 hours, or 3 separate episodes in 24 hours, 3 episodes in 24 hours. So that is what the guidelines talked about today. So electrical storm is a life-threatening arrhythmia that involve recurrent episode of ventricular arrhythmias. So it's defined as 3 or more sustained episodes of ventricular tachycardia or ventricular fibrillation, or inappropriate implantable cardiovascular defibrillator shock that happened over a period of 24 hours. Now, the issue of bringing ICD in is part of the recent definitions. Before now, we're talking about ventricular tachycardia, ventricular fibrillation, but because of ICD, inappropriate ICD shocks that have now been part of the whole syndrome, so it has now been characterized as part of the definition. So most have underlying structural heart disease, but in some cases, you may not see any underlying structural heart disease. For example, this patient that we treated had a dilated chamber, and but the coronary arteries are clean, so it's a non-ischemic cardiomyopathy. That is what she had. So the condition occurs in about 10 to 20% of patients with ICD patient. So patients who have experiencing acute MI, as I think the 3rd case we presented, what happened there was just only MI. The only presentation he had is constant ventricular tachycardia that you shock after a little while, it returned back. There was no other thing the man presented with. That was how he presented. Remember, he's an elderly, also diabetic, so autonomic features may have been blunted, and the only thing is that she say that I have palpitation, and he passed out. That was how the wife brought him to the hospital, and we happen to know that this guy had an MI. So the incidence of electrical storm is, however, lower in patients who are placed on ICD for secondary prevention. The MODI 2 subgroup or sub-study of 719 patients, 4.4% developed electrical storm over a range of 20 months. In another trial, 20% of those who receive ICD for secondary prevention experienced electrical storm during a period of 31 months of follow-up. So intracardiac electrocardiogram that were recorded during this episode showed that most were due to VT and occurs in about 9 months after the ICD implantation. So usually a specific trigger for electrical storm is not easily identified. In the shock inhibitions of evaluation with Ezaimilide, the SHIELD study, the trigger for electrical storm was found only in 30% of the subjects. Electrical storm can be precipitated by acute myocardial ischemia, electrolyte imbalance, hypokalemia, hyperkalemia, hypomagnesemia, worsening heart failure, sepsis, or poor compliance with antiarrhythmic medications. The role of autonomic nervous system in triggering and maintaining electrical storm is also well recognized. Hence, the sympathetic activation has been strongly advocated as part of the treatment for electrical storm. How do we classify electrical storm? We classify based on the etiology. If it is it a monomorphic ventricular tachycardia? For example, the first patient we presented with monomorphic ventricular tachycardia. That is the commonest form of electrical storm that we do see. In fact, the second patient is also, because they sent the ECG to me on WhatsApp while I was talking with them, it's also monomorphic ventricular tachycardia. The 3rd patient I also presented that had a retired medical doctor is also a monomorphic ventricular tachycardia. So it's the commonest form of electrical storm. The polymorphic ventricular tachycardia can, or point can also be a part, or it can also be a presentation here of ventricular fibrillation. So in ischemic or non-ischemic cardiomyopathy, vulnerable substrates for reentry lies within the heterogeneous area of the scar myocardium, and that is what generates the monomorphic ventricular tachycardia. So after an MI or a non-ischemic cardiomyopathy progresses, the heart undergoes structural changes. Fibrosis lead to scar formation, which create area or conduction blocks. However, bundles of myofibrils can survive within this fibrosis, particularly around the borders of the scar. So slow conduction through this region provide a pathway for electrical reentry to occur. Hence, a trigger can occur through there where a patient will now start having ventricular tachycardia. So monomorphic ventricular tachycardia can be asymptomatic, or it can present as a patient in cardiac arrest. For example, this first case we presented from CardioCare had a cardiac arrest and it had multiple shocks. So the degree of hemodynamic compromise depends upon the heart rate, the left ventricular function, the presence of heart failure, or the degree of asynchrony that this patient have. So is the patient on amiodarone beta blocker or other pharmacological agent? It also depends on that. So another issue again that we also that also causes, as we said, is the torsade de pointes. So polymorphic ventricular tachycardia occurs when ventricular activation sequence on the surface telemetry ECG consists of a biato beta bit variation in the QRS complexes. The polymorphic ventricular tachycardia has frequently different mechanisms. So this is what a torsade de pointes looks like in patients that presents either in ventricular storm or they have one episode of torsade de pointes. So ventricular fibrillation, is another chaotic rhythm that also can keep occurring and lead to electrical storm in patients. Now, it happened, the mortality among this group of patients is very high, almost 85 to 95%, except you have easy way of shocking them and easy recognition and shocking them. But in our environment where we don't have AED in all the center, you go to a mall, you go to a shopping center, there's no AED. But in the West, if you go to any shopping center or any market area or any public area, any company, you have all this AED and it's easy to recognize, and a patient can be defibrillated and while waiting for the ambulance to come. So what are the risk factors? Here we talked about coronary artery disease, QT prolongation. I think this our patient also had QT prolongation. Heart failure will reduce ejection fraction, electrolyte imbalance. These are all part of risk factor. Things that we can also correct, like hyperthyroidism, fever, infection, Brugada syndrome, prolonged QT interval, early reproduction syndrome. These are all part of the risk factor. Now, the presentation, the patient may just complain of palpitations, that I do have palpitations, because that is one of the key things that ventricular tachycardia present, or dizziness, or often syncope. And sometimes it may just present with sudden cardiac arrest. The patient just pass out immediately. He may not even complain of anything, he just pass out immediately, and he may be lifeless on the floor. So I see the patient complaining of several shocks. You also think of something of this nature. So the type of arrhythmia is very important. And as we said, monomorphic VT account for about 86 to 97% of people with electrical storm. So the primary VF may account for 1 to 21%. Miss, a patient may have miss of this arrhythmia from ventricular fibrillation to ventricular tachycardia, may miss up. You may see that really in some people in about 3 to 14%. And also polymorphic VT in about 2 to 8%. So the key differential here are wide complex tachycardia. And if you see a patient with wide complex tachycardia, you are not sure of what exactly is that tachycardia. Treat the patients as a VT, because if you don't treat the patients as a VT, the patient will pass out, will pass away. And if you treat the patients as a VT and assuming the rhythm is not a VT, it's a supraventricular rhythm that is presenting with aberrancy, your treatment may also help that patient to survive. So these are the reasons why we say treat the patient and don't leave the patient. Treat as VT if you are not clear. So the regular monomorphic, we have also listed that the one with regular tachycardia, monomorphic ventricular tachycardia, supraventricular tachycardia with aberrancy, supraventricular tachycardia with bundle branch block, accessory pathway, atrial fibrillation or atrial flutter with bundle branch block. All this we present as Y-complex tachycardia. The irregular ones, atrial fibrillation, atrial flutter with variable blocks, then with left bundle branch block, all of them we present with Y-complex tachycardia that are irregular. So effective treatment of electrical storm require the knowledge of the arrhythmia mechanism, the therapeutic options, the ICD programming, and emerging techniques for refractory of these arrhythmias. So now, in the emergency, how do we address it? One is that it's a medical emergency, and initiate your ACLS guideline immediately, especially if the patient is pulseless. Then if there is a need, you can sedate the patient and continue. So the management of electrical storm even
It sounds like we might have lost Dr. Edafe in the call.
Yeah, it seems so. Dr. Edafe?
Okay.
Dr. Edafe, can you hear us?
I will message him, but while he reconnects, one point I'd like to make, it I think he's, always make sure you're checking the patient's pulse. Don't necessarily trust a device has shocked for the right reason. Not that they aren't typically right, but devices can also have invalid shocks as well. So just because a patient reports shocks doesn't mean they were having VT or electrical storm necessarily. You always want to do some more digging on those aspects.
Yeah, that is a very important point. In fact, in this case, after we put in the ICD, the patient reported and then put on IV amiodarone on all the different drugs. Patient reported 3 more shocks and we were still quite confused. When we interrogated the device and other things, we didn't find any evidence of shocks. All of that was not really there. So afterward, the patient now said, well, she was feeling a sensation, or she felt just the trauma of the previous shocks that she was still feeling going on. So sometimes it's very good to also confirm and cross-check what is happening so that you don't continue to escalate medications. Dr. Edafe, welcome back. We lost you for a bit.
Yeah, I'm back.
Okay, so go ahead.
Okay, AJ, you have to give me hosting.
Oh,
AJ, yes, because I've lost the hosting rights. Okay.
There you
so
go.
that I can share the slide back again.
Okay, we got you as host.
Yeah, you have made it. Yeah, same. Okay, so this is where I was, where I left. So what I was saying, once you identify the patient, initiate, if the patient has ACLS and is the electrical shock, you can get electrophysiology consult and ECG morphology, know the type of ECG morphology. As we said, the commonest cause is monomorphic ventricular tachycardia. You can initiate your amiodarone, beta blocker. We'll discuss the dosage shortly. Beta blocker, lidocaine, if it's an ischemic event that leads to it, where lidocaine is good and beneficial. Studies have shown that. Sedation and other means can also be used for this group of patients. So identify reversible cause and treat them as much as possible. So for ICD management, we said that patient with ICD who develops electrical storm often present with multiple ICD shocks. Like the second case I told you that happened 2019, yeah. 2019, that is the second case. So the lady had an ICD, but from the event sent to me, it is not the ICD that is generating the shock. Rather, the lady has recurrent VT that does not respond to any form of shock. That was what happened in that case. So this shock can be quite distressing. And when the patient keep having ICD shock from time to time, is a really pathetic problem. And the fear of another shock coming along can even trigger the arrhythmia to continue its own pathway. So the management, as we saw in this case, the patient was from ICU, the patient landed in the cath lab and back to ICU after the ICD and the angio. So these are all the pathway for management of electrical storm, especially the antiarrhythmia, the ICD, cath labs, EP, and back to the cath lab. So the multiple ICD shock, if the problem is coming from the ICD, the first thing you look at, is it a phantom symptom or phantom shock? Phantom shock here means that the patient just feels that the ICD is shocking, but it's not actually shocking anything. So you just reassure the patient. Inappropriate shock is that the ICD is giving shock, and those shocks are not actually directed to the real arrhythmia. Maybe probably the sensing of atrial fibrillation, supraventricular tachycardia. That is why the ICD is inappropriately shocking the patient. So you have to reprogram the device. Sometimes you have to switch off that, switch the shock therapy off, and manage medically and reassure the patient, get an EP consult, and take up with your electrophysiology to ensure that this patient restore his ICD back again. So then for patients who require, who are in our setup in the sub-Saharan Africa, what I usually advise is the pharmacology therapy will be the first approach here. Pharmacology therapy, the beta blocker are very key to the management here. The beta blocker, one is that they are sympathetic nervous system activations, and they decrease that. And another thing is that they also reduce anxiety that occur after multiple shocks occurring in them. So the drugs that have been tried here are propranolol, esmolol. They have been really tried here, and they have been found to be very useful. Propranolol can be given at IV propranolol 0.15 milligram per kg over 10 minutes, and you can give up to 10 milligram. The issue here, I don't know of Ghana and Kenya, but here is that we don't have IV propranolol most time available within our coffer. So more of the propranolol that we have here are the oral propranolol. We have excess of it. So if you don't even have the IV, I also advise that use the oral. Can give 40 milligram every 6 hours until you ensure that that patient is out of the electrical storm. Then if you are using esmolol, it's still the same thing. These oral beta blockers are not very available everywhere in Nigeria. So you have to source for them. You have to specifically request for them to take them along. So, but if you have esmolol, you can load 0.5 milligram per kg, use up to 30 milligram over 1 hour. Then you maintain that. So beta blockers are very good. Metoprolol, yeah, is also If you don't have the other one, metoprolol can also be used. Amiodarone is a broad spectrum anti-arrhythmic agent. It works primarily via class 3 activation, that is the potassium channel activation. It can also act as a class 1, that is sodium channel blocking, can also act as class 2, class 4, that is the calcium channel. It can also go through all those mix. So amiodarone has multiple ways of getting the work done. So amiodarone has been shown in multiple trials to reduce the frequency of ventricular tachyarrhythmia and is very commonly used in electrical storm. There are many studies to that. I don't want to quote all the study, but this is one of the study in the optimal pharmacological therapy in cardiovascular defibrillator patient. The OPTIC study, 412 patients with ICD were randomized to beta blocker plus amiodarone and sotalol. The frequent shocks occur in 7.4% of patients. Yeah, 7.4% of patients in the beta blocker and 1.4% of patients with beta blocker and amiodarone and 2.3% of patients on sotalol monotherapy. So amiodarone is very effective. So we can use amiodarone, but the initial dosing of amiodarone, when you are using it, you should use it with use it as an IV. You can preload the patient with 150 to 300 milligrams of amiodarone. You give it as a bolus push. Then after that, you put another maybe 600 to 900 on infusion and run it for the next 24 hours. So until you are sure the patient is out of the VT, you can combine this amiodarone with another agent. Not that you wait for amiodarone to fail before you bring in another agent. That is not the tricks of managing it. The tricks is that if you think that combining 2 anti-arrhythmic agents will give you a better yield, go ahead and do the combination. For those that have sotalol exact its action through a combined class 3, that is potassium channel, and class 2 beta blocker action. Most of the clinical effect is thought to be through its class 3 effect and leads to the prolongation of repolarization and thus increases the refractoriness of the muscles. So this is where sotalol comes in. If you have it, is very good. Then, as we said, lidocaine for ischemic heart disease and electrical storm, lidocaine is very, very effective in doing that. Lidocaine is thought to be first line compared to amiodarone if you are dealing with an ischemic cardiomyopathy that is leading to the electrical storm. So, but you can also combine the two. The issue here about lidocaine, once you give it, it causes a prolonged refractory length of the muscles and keeps the muscles from having that excessive excitation from the focal point. But it is effective when you use it in ischemic events. So other things that you also think of here is for people with ventricular fibrillation, you can also, if you try the other method and it failed, you can also give them magnesium sulfate, can also be an option. So the non-pharmacological therapy here for malignant arrhythmia can also include intra-aortic balloon pump or percutaneous left ventricular assist device. The reason here, but for all this, for example, patients will have a better coronary perfusion pressures and dramatically reduce ischemic substrate for those that have ischemic cardiomyopathy. So we can do that. Then ablation is also another thing. Catheter ablation is another thing that we can also use. But before now, prior to now, the teaching was that rest the myocardium before you take the patient for catheter ablation. But a lot of technology has occurred and a lot of development has occurred. So this can be done on the table, even while the patient is having incessant electrical storm. Then deep sedation is another issue here. The anesthetist can help us here because it's more of a multidisciplinary measure. Anesthetist can help us here to give a deep sedation to the patient, and that also helps to reduce the overdrive of the sympathetic action that trigger these arrhythmias. So intubation can be done, and when intubation is done, you keep monitoring the patient on the monitor and continue your IV medication. So these are part of what the anesthetist do. Propofol can be used, desmetadine can also be used, and you can also combine it with the benzodiazepine. These are all that the anesthetist can give us. Arterial line, yeah, can also be used to get monitor the patient, get the blood gas for the patients, and continue the therapy for the patient. So the key thing about electrical storm is that if you identify the cause, if you can identify the cause, treat the cause. For those that have reversible causes, like we talked about in the third patient, that third patient had a STEMI to a mid LED. That was what that patient had that triggered that electrical storm. And after the restoration of revascularization, the patient did not have that electrical storm anymore, even though the patient was still on amiodarone for continual monitoring. So for those that have electrolyte imbalance, ensure that you correct the electrolyte for them. Those that are having fever, hyperthyroidism, correct all that. And when that is done, those people tends to restore the myocardium from that hyperactivities. So these are things that we must do for those group of people. In the absence of any of such, an ICD is should be planted in them. But the key things when you want to consider ICD in them, for a patient who had electrical storm, ensure that that myocardium is stable before you take the patient for an ICD implantation. Remember that the first case we discussed, it was a single shock we gave to that patient. As at that point, we can't characterize that patient as having electrical storm. That was why we took the patient to the cath lab. So it was in the cath lab, we're already in the procedure, in the midst of the procedure. That was where we started seeing things that we never thought of. So we're already in the midst of the procedure, and we just have to get it over, and that was why we did what we did. But for a patient who has multiple attacks, before the procedure, ensure that the patient optimal medical therapy is obtained, and the patient myocardium is quieting for 24 to 48 hours before you take the patient into the cath lab. If not, you will still run into difficulty of positioning that lead into that right ventricle, because immediately it touches the ventricle, it stimulates unusual arrhythmia for you. So other things that we can also use is, if they are available, is the basis of the stellar ganglion block. You can do that if every other thing fails. For example, the second patient that I presented, that was what I was thinking for that patient, but he did not get to us before the patient passed out. So the stellar ganglion block, the key thing here to do is just follow the principle of approach. Now here is that you sat a needle until that needle gets to the Shasanga tubercle. Once it gets to the Shatnaga tubercle, you inject your lidocaine or inject your medications on it. So once you inject on it, then you withdraw it to inject on it. The only difficult thing here is that that tubercle is at the C6, is actually the extension of the C6 tubercle, and you have the great vessels like the carotid artery, the carotid artery, the jugular veins, and also the vertebral artery. They transit through that area. So it is better that you use ultrasound. But if you don't have an ultrasound, the landmark to get it done is that palpate the trachea at the point just beside the trachea, advance the needle down. If you don't have that, you are in a terrible condition, you don't have that, advance the needle down, and once the needle hit the tubercle, it stops. It cannot pass through because it's hitting a bone. So the next thing you will do is that aspirate back to ensure that there is no blood in that needle. And after you have done that and it's on that bone, then you jet your medications on it. That terminates the sympathetic supply to that region. The only thing here is that it can give you Horner syndrome. Those are the major complications of these techniques. So you can see that other ultrasound, it can be done, and non-ultrasound, this is the landmark approach. Just beside the trachea, you just at level of C6, just go down beside the trachea, avoid. Or the lateral approach, you go behind the vessels that the veins and the artery that transverse from the heart to the brain, and you still hit the same tubercle, but ensure that you are not in any of these vessels when you do that. So the best thing is to do it under ultrasound so that you avoid entry into any of these vessels. So other things that can also be done apart from left ventricular assist device is that you can also put the patient on extracorporeal membranous oxygenation, that is ECMO. So why continue intubating the patient and ensuring that you restore quietness to the myocardium? Then stereotactic body radiation is also a therapy. We don't do all that here. So the prognosis is poor for a patient who keep having recurrent electrical storm. So even the AVI trial, 5 patients with electrical storm have an increased risk of non-sudden cardiac death occurring among them. Even the MODI2 subgroup also show that they also have a high increased risk of 7.4% of dying from suddenly. So a patient who has electrical storm must be followed closely and must be managed accordingly. And according more time, more frequent OPD visit, and check the medication, and also more frequent programming to see whether this patient is actually having anti-tachycardia pacing. Because if the patient is having anti-tachycardia pacing in response to VT, you may not pick them up, and the patient may not even be aware of it. It's only when a shock is delivered that the patient be aware of it, so that you can optimize your medication for them. So a patient who had a VT, like this our patient now, who had a VT a month ago, if the patient come today and I ask the patient, have you ever had a shock? And the patient say no, that does not mean that the patient doesn't have a VT. So you have to check the ICD to see whether the patient had a VT and a shock, because the ICD will record it as a shock, but of a truth, what the ICD give is anti-tachycardia pacing. So all these are things that help you to modify your medication, fortify your medication, to quiet down myocardium and avoid frequent shocking. Thank you very much. So time for questions. And
thank you very much, Dr. Edafe. Very fantastic presentation indeed. I really enjoyed it. It's very important for us to note it. This is not one of the cases that a cardiologist will sit down in their office or just sit down and be telling the house officer what to do, add this, subtract that. This is one of the cases that calls for us to be on ground. So we don't have many emergencies that call out of our home in clinical cardiology. But this is one of them that should get you seated in the ICU and then also following up the patient to the cath lab. Thank you, Dr. Edafe, for that. We'll take any questions or experiences that we've had in this regard that will help us. My order is breaking. Or are other people breaking? AJ, can you hear? Oh, nice to see you, Dr. IJ.
Hi, how are you?
Fine, thank you.
Okay, good. So Dr. Edafe, this was a great presentation. Hi, Dr. Iseko. So I just wanted to mention a few things just to reiterate what you were saying about VT Storm, because I think that it's important to, because you have ventricular tachycardia that a patient shows up with, they had an event, it happened, and that's it. VT Storm or VF Storm is a completely different beast. And like Dr. Iseko said, that is, an emergency and you need to be in the lab. There are a few things that I might change with regards to management of the patient. First thing would be that when the patient comes in, has had more than 2 events in a 24-hour period, the patient gets IV amiodarone, no questions asked. And then you start doing all the other things. And of course, as you're getting the IV, I'm hoping that we're getting an EKG, we're getting a history from the patient, because, you do want to figure out what your etiology could be. Because of the fact that if somebody has VT or VF, and has been shocked or has gone through CPR more than once in a 24-hour period, this is somebody who is telling you that they're really sick. And so you want to make sure that you are coming in front of whatever it is that they are presenting with. So it's very helpful when you have a cath lab or, you're able to do a coronary angiogram really early in the hospital course, because you don't know exactly what might be the cause. And like was shown in the case that was presented today, if it's due to acute event, then that's something that you could definitely take care of sooner rather than later. And so actually, a lot of times, even though now, previously, it used to be seen that it was like an ST elevation equivalent. So if somebody came in with VF, then you would just take them straight to the cath lab. Now, folks say, oh, give them amiodarone, let them quiet down, and then maybe take them a few hours later. So you do not have to take them immediately. You can take them, but definitely within the first 48 hours, you would want to do that. The second thing that I would mention is that, of course, the patient that has an ICD the way you would treat a patient with an ICD is very different than the way you would treat a patient without an ICD. The patient without an ICD, obviously they haven't presented with this before. At least all things being equal. Let's say, money is not a factor and, they've seen a doctor before, they haven't presented with this before. And so you are allowed to be a little bit more esoteric with your differential diagnosis. So that's where the long QT, the Bugadas, the HOCM, all of that stuff, in addition to the ischemic heart disease, comes into play. An echocardiogram becomes really important, as well as looking at the EKG for subtle signs, looking at medications that they might be taking that might cause a prolonged QT, things like that. Then I think, the other things that I wanted to make mention of, the sympathectomies, and it's a very difficult procedure to actually do. And a lot of times is not as successful unless you have a lot of training in that area. So, they say when they describe it, it makes it seem like, oh yeah, all you have to do is put your needle right here, you give some lidocaine and boom, it all ends. And actually that's not necessarily the case. So what I would suggest would be IV amiodarone, giving lidocaine if you think that there's ischemic heart disease, but being very careful about your lidocaine levels, making sure that you are not giving them too much, because then you could have neurotoxicity as a result. The beta blocker I could do or do without it, but making sure, and if the patient continues to have VF storm, then you should call your anesthetist and sedate them. And that will buy you time for you to figure out all the other things. And I think that's what I wanted to say. Oh, one last thing. If a patient has an ICD, when the patient comes to see you, always check the ICD, specifically because of what Dr. Edafe said. So, you know, the guidelines state that for patients who have an ICD, either they should be checked at home every 3 months, or if they're being checked in the clinic, they should be checked at least every 6 months. So there are patients that I see on a regular basis who nothing is going on with them, nothing is happening with them. I see them, you know, or I do a remote monitor, but I see them at least every 6 months just to make sure that they're not having those events that you were talking about where they have VT and they're being treated with painless therapy that the patient is not aware of, because that will help you become more aggressive with your medical management. And thank you.
Thank you very much,
Thank
man.
you, Dr. Joma. Great. Yeah.
Very insightful.
Great. Yeah.
AJ, do you have anything to add?
Well, no, thank you, Dr. Joma. Thank you, Dr. Edafe, Dr. Iseko, for all of this. Has been amazing. One thing I want to mention is we kind of had this conversation the other day, Dr. Edafe, about considerations from an ethics perspective. So just remember that, these can be very, as you mentioned, it can be very painful, both mentally and physically, for a patient to be shocked many times. So it should always be a consideration. And I think you should always, make it clear to your patients when they're getting a device, the implications of having a defibrillator in them, because it could very well save their life, but it could also be very emotionally damaging to be shocked many, many times, hopefully for the right reasons. So I just think, we always want to make sure when we're speaking with our patients that they know that this is a possibility and that we're managing their care so it never becomes a reality. But ultimately, these do save lives, and many people are on this world because they had a device. So,
yeah.
I don't know if you want to respond to any of the comments or to add anything. If you have a question, please just put it in the chat box or raise up your hand, and then we can unmute you so you can speak. Okay, that's over to you.
Okay, very good. The comment from our electrophysiology, Dr. Joma, is very well noted. Dr. Joma, one issue about this side is we don't have a remote monitoring process. So because of that, once the patient leaves you, you don't have any access to that device. So you only have access to the device when the patient comes back to you and you put the programmer, you on the programmer and put the programmer head on the device. So that second case I talked about that happened, the patient had an ICD implanted. It was a very pathetic story. I discussed that case with Dr. Mirile and Dr. Ms. Ogundu. That was that 2019. I was on call with them and we talk at length over the case. The question is that what could have been done, because every medication that is available to our disposal, the cardiologists at that end use it. Amiodarone, he used it. He also combined amiodarone with lidocaine. But the patient keep having recurrent shocks. I'm even checking whether the cardiologist is with us here, but I have not seen him today with us here. We keep talking and we did everything on the phone with him and there was no result. What could have been, what should have been done different? There was no magnet to put to disable the therapy. So what could have been done that we didn't do for that case? So I think anytime I think of it, is always a nightmare.
So I unfortunately, I didn't hear about the case. So I'm going to be asking some questions, which you already discussed, but was the shock appropriate?
Yes, the answer is yes, ma. That shock,
Okay.
those shock were appropriate. Because
So, I mean,
why I say so is that the cardiology put the patient on a monitor, and also once that device give a shock, once the give a shock, they also on surface EKG, also printing, as several of those EKG were printed, and it's clear that this patient is having monomorphic ventricular tachycardia in hemodynamic compromise.
So if that is the case, and did they do a coronary angiogram?
No, the thing happened, this event started 8 p.m. in the night, and the woman died 2:30 in the morning. It happened in a different city. So
this is the thing,
aim was to move the patient the following day.
Yeah.
Ma?
So unfortunately, the only thing that you can do in that situation is to intervene, unfortunately.
To intubate.
This is the thing, to intubate the patient, because what you're trying to do is quiet everything down, because all that sympathetic tone is causing more VF. I suspect that the patient probably had ischemia. So there are two things that will cause you to have it like more and more. Number one would be ischemia. The second thing would be maybe CPVT, which is a specific type of ventricular tachycardia that is, I don't know how to pronounce this word, but it's like cathepneumogenic. Basically what it means is that the more catecholamine surge that you have, the more VT you're going to have. And so every time you have a shock, it's actually going to increase increase it some more. So, either one of those things could be the case, in which case intubating the patient would have been the only thing that would quiet things down. Because this is the thing, if you put a magnet on the patient, right, then the patient would have VF and not get shocked, but it doesn't really help you, right? Because then the patient would pass away. So in that particular situation, I think that, the only thing that you could do apart from figuring out the cause and, trying to stop the VT, like the only thing you could do is stop the VT, which was, give magnesium, give amiodarone, give, intubate the patient, sedate the patient. Those are really the only things that you have in your arsenal. And if all of that is not, successful, then unfortunately, this is where your hands are tied and you cannot do much else.
Much else. Thank you, ma'am. Dr. Iseko, over to you, sir. Dr. Iseko muted himself. You muted yourself, sir.
Oh, sorry. Thank you. I don't know if there are any other people that have any questions, so that we can, talk about that briefly. Any questions so that we can easily just address them now? Or anybody that has anything to add, maybe from experience? Dr. Emmanjuel, good to see you, because when we have issues, we're going to call you in cardio care so that you can intubate like you've heard. Dr. Odessa, I don't know if you have
Dr.
anything to
Apia.
add.
Yes. Dr. Apia is with us. Apia from Kumasi.
Oh, great.
No, just that I completely agree with Joma that that patient may have had coronary artery disease, acute coronary problem that needed attention. And unfortunately, maybe Edafe is not close to the environment where the event was happening.
Yes, that was what happened, sir. The patient is in a different city, and it takes 4 hours to get to where I was, and it's happening in the night. So the aim was in the morning. The patient will move early in the morning, but unfortunately, the patient didn't survive the morning.
I have a question about the patient.
Sorry, go ahead.
Oh no, I just wanted to know when they interrogated, did they interrogate the device at all?
Oh, that is the biggest thing, Dr. Joma.
Oh.
The device was not, as I said, the device is St. Jude.
Yeah.
It was a St. Jude device. It was implanted in London. So they returned home. The woman went to her village. Yes.
Yeah. I think that, it's one of those things where, it's one of those things where, and this is something that, of course, it has to happen on a more policy-wide level, right? Where we have Nigerians who are going to different countries, getting devices, coming back home, or getting their devices implanted at home. We really need to talk about a network of physicians that have
you are correct
to interrogate a device in every part of the country. So it cannot be that, Abuja, Lagos, and Port Harcourt, and maybe Kano are the only places. It has to be there have to be places that are identified along the country, similar to the way that we say, AED should be everywhere. We should have a network of cardiologists interested in, interrogating devices, and having the capability of interrogating devices so that we can talk to companies and basically tell them, hey, our patients in the country have your devices. We need at least 10 or 12 programmers around the country, have people who have been demonstrated to know how to interrogate devices so that this is not an issue.
Good. For example, in the country now, Lagos, Abuja, Port Harcourt, we can comfortably interrogate Medtronic and Abbott devices. Apart from these two devices, I don't know of any other device that we can interrogate in Nigeria, because we have programmer for these two companies. So as you raise up, the same thing Dr. Merile also raised when the event happened that time, 2019. He also said the same thing you just mentioned, that we need to talk to our people. But the question is that, that the people, they don't inform you before they move anywhere they are going to. And when they get to wherever they are going to, they don't ask them how are you going to be managed when you get back home. So it depends on the, you practice in the US. I've seen that in some of these developed countries, depend on if you go to a particular hospital, the hospital does more of Abbott devices, the other one does more of Medtronic, the other one does more of Boston, and so on and so forth. This is how you guys repeat it among yourself. So it depends on where that patient enter. If the patient enter into a place where there is more of, they just bring it and throw the device at you. They don't even consider whether you are going back to a remote place in Africa where that device needs to be checked on. So these are the issues. Maybe Dr. Oga has something to say on it.
I think that NCS as a group will begin to advocate, but as an individual, CardioCare has been trying to reach out to some of these companies to at least put one of your programmers in the country, because we've had on occasion to take out people's devices to exchange them to a more familiar device, because, they will just not find anybody to do about it. So it's some of the things that we need to do both personally and if there's a programmer at least somewhere in the country. Most cities are accessible by flight within 6 to 8 hours. And with WhatsApp, a lot of telemedicine can happen. Dr. Oga said that there's somebody that has St. Jude somewhere in Lagos. Yeah, I think I heard of that, but I think it's an old one. It's not able to interrogate all the newer devices. So I'm not so sure about that. So this network is not very clear, and a lot of patients have devices in Nigeria. That's the truth. Some we have put and we know them, but I think there are at least 2 times the number of patients that we have put that have devices from overseas. And we have to find a way to, give them still support, give them still the care that is needed for them. But for now, the main support we have in Nigeria is Medtronic for device therapy, even training, and all of that. So that's what's happening. I know that AJ has helped out, and Peace for Life has really been of help to bring out. I think AJ wrote something in the chat. Yeah, he said he's talked to somebody from Abbott, and they should bring a couple of programmers from Abbott next year. So that will be really fantastic for us to have. So we'll look forward to that, AJ. So we'll have a lot more programmers in the country. And with the Pace for Life program, we actually have a lot more patients benefiting from these devices. I foresee a situation whereby with the increased number of cath labs, with the increased number of operators, with the increasing general state of health in Nigeria, that in the next 5 years we'll have quite a population of patients with devices, and that could be catastrophic if there is no capability to manage them. As of now, very few people are able to interrogate and do all of that. So that's quite important. If you look on your screen, I've put a short summary. But Edafe, I don't know if this encompasses most of what we've talked about. So something that you can take home.
Yes,
you can just screen
that
grab
is
it.
fine.
Thank you, Dr. Lambert. So he says in Ghana they have a similar situation, that patients get implanted abroad, and when they have issues, they are handicapped there in Ghana as well. So thank you, Dr. Lambert, for sharing with us. So this is an African issue, really. It's an African problem, really, and it's something that we must find a collective solution to. I really will hope that someday somebody will come up with a universal programmer. I will really hope that will happen someday. Let me just give a short summary based on what Dr. Edafe has presented for those that joined us late. If you look on your screen, you will see a short pager like an SOP that you can just put up somewhere. 3 or more sustained episodes within 24 hours of VT, VF, or appropriate just from an ICD. But of course, for our environment, don't wait till it gets to 3 or more. Once you have one, you should begin to have that idea. Once you get to the second time, begin to think of it like a VT storm or an electrical storm. The typical etiologies are structural heart disease, acute MI, inherited arrhythmic syndromes. In the patients we presented, they had one person had structural heart disease, the most recent patient, and the other one had acute MI, another had an ICD in situ already, for which we suspect they may have been an ischemic event. And of course, we must remember that electrolyte derangements, a new STEMI, sepsis, worsening heart failure, ICD dysfunction could all be precipitants in this. There's a very poor outcome and must be treated as an emergency. You need to do a 12-lead EKG, echo, troponins, electrolyte panel, thyroid panel, and ICD interrogation is important if the patient has an ICD, but Dr. IJ added, it's important that you interrogate the patients regularly so that patients that do not have shocks, you are able to make sure that you have some kind of input and know when things are already going bad before they come down with multiple shocks. Most of the treatment centers around IV amiodarone, and that Dr. Edafe said in our environment, if you're unable to differentiate clearly between two of them, consider giving amiodarone. You can't go wrong most times with amiodarone. Now, I know that IV amiodarone is not available in every part of Nigeria. And in the case Dr. Edafe discussed, I don't know if IV amiodarone was available or oral. For a lifetime, when I trained in the Southwest, it was mainly high-dose oral we're giving. We did not have IV amiodarone, but IV amiodarone is now available. IV lidocaine, which is preferred in MI, can be used, and do not hesitate to combine, but remember to check for levels if you have the ability, or you can, and then look out for neurotoxicity. Beta blockers and propranolol is quite particularly useful in addition, just quieting down adrenaline discharge. Electrophysiology studies, if available, unfortunately, there's none available on a continuous basis in Nigeria at the moment, to my knowledge. And then other treatments. Patients that have had an MI need revascularization to help. In the patient that were presented, while we're having the multiple shocks, we did the angio as well. After putting the ICD, we did the angio as well, which was clean. Treat any precipitant that is there. Sympathectomy was described by Dr. Edafe as relatively looks straightforward, but as Dr. Ige rightly pointed out, it looks straightforward, but it's not as straightforward as it looks. It could be difficult. ICK is critical. Once you're quieting down the place, wait for 24 hours or thereabout, let the myocardium quieting down before you go to put an ICD, but consider 24, 48 hours. And then sometimes patients will need circulatory support, IABP, sedation, and or intubation to just quieten down everything. And this is why you need a multidisciplinary team to help in the management. As AJ told us, remember psychotherapy and detailed counseling. These patients need to know that, yes, it's a life-threatening treatment, life-saving treatment, but the trauma of having shocks can be quite significant in their quality of life overall. And there are quite a number of people to talk about quality of life in patients with ICDs, and it's important to look at all of this together. I think this summarizes largely what we have said so far. Dr. Oga suggests that we'll repeat this topic at an LCS meeting. We definitely will look forward to, once we get the opportunity, we are ready. Anytime people send patients for ICDs, or first of all, I prefer patients do not, doctors in Nigeria do not send patients abroad. We have centers in Nigeria, in Lagos, multiple in Lagos, in Abuja, that can do these procedures. It's very important for cross, we can talk together, we can improve the skill together, we can interrogate together. When you have an issue, it's easier when for a patient you have seen, and for a patient you don't know from anywhere. To start, it can be quite challenging. But if you have to send them abroad for whatever reason, including the patient's choice or preference, please make sure that you include the kind of devices for which you have. And for now, largely Abbott, thanks to Pace for Life, who has been quite supportive, and Medtronic, who are almost fully on ground. It's quite important to note those ones. Finally, it is important to note that I think that any practice that is represented here should make sure that they have a functional defibrillator, not just an AED, but a full manual one that can also do what is necessary in the case of an emergency. Because when this thing is happening, you don't have that time. You don't want to be pressing the thing and let it be analyzing, and have that time. That time could be quite difficult and could be a problem. So make sure that you have a functional defibrillator in your units. As we do that, there is some support from Pace for Life for those that absolutely need it and in dire need. But apart from that, most hospitals in Nigeria can afford a defibrillator once they consider it a significance. And that is our job, not just to give patients treatment, but to advocate that the milieu for better treatment is available all around. So thank you very much. If there are any other issues, we'll
Dr. Iseko, Dr. Iseko, before you go, there is a question that I said, please, after intubation, do we still continue amiodarone? The answer is yes. Intubation is an added therapy.
So the amiodarone is typically given as an IV bolus dose, and you continue in infusion, typically for us 24 to 48 hours, and then we transition to oral. And then in the case of a VT storm, electrical storm, you may want to add IV lidocaine. The normal lidocaine people use to anesthetize wounds most times will still serve. Look at the dose, look at the percentage, and then recalculate it. Of course, it is a critical drug, so make sure that you do cross-checking with a second party. When you calculate your dose, speak out what you have calculated and how you arrived at it, and let somebody else cross-check it. So don't say at the all in all, somebody cross-checks, and then you might want to add a lidocaine as well. So that will be helpful. If you do not have IV amiodarone, of course, everybody has lidocaine. So if you don't have IV amiodarone, you can start your lidocaine, and then occasionally we've tried in the past before we've used oral while giving the IV lidocaine, and it has been quite helpful to, if I must say. So rather than give nothing and say there's nothing, and then be assured that you can reach out to anybody on the group. Dr. IG has been fantastic and giving great support to us here in Nigeria. AJ and lots of the members of Pace for Life are not just helping, they're actually passionate about helping. You can reach out to Dr. Edafe, you can reach out to me, and we can easily advise wherever you are to a large extent. Okay, AJ, I'll hand over to you now. I think my job is done.
Perfect. Thank you, Dr. Iseko. That was awesome. I really appreciate that.
Thank you very much.
So I don't know how much time everyone has, but we can quickly, let me take back host here, go through the quiz. Has anyone had a chance to look at it yet? At all? If not, we'll go through it now. Can everyone see my screen here?
Yes, mate, we got it.
Perfect. Okay. So once again, these are Abbott focused quizzes because the gentleman who produced these and gave them to me works for Abbott. So it will hopefully get some Medtronic material as well down the road. But for now, we'll go ahead and get started here. So does anyone want to take a shot at this first question? The red shock button on the Abbott programmers. So you have a VVI button, which puts it into emergency VVI, and then you have the red shock button. Will it instantly shock the patient when you press it? Anyone want to take a stab at it?
I'm going to go with no. I think it's then you need a confirmation to go ahead and determine whether you're going to deliver the shock or not, because given the location of the button, you don't want to accidentally lean on it perhaps. So there is definitely a second step before it delivers a shock, would be my understanding.
Yep, exactly. Thanks, Jared, for that. Yeah, no, that's exactly the point. When I first saw these, when I first started working for Abbott, I was terrified of this button, but there are extra steps involved. So I have used this a number of times, not really much in an emergency setting, maybe once or twice, but more if we decide to cardiovert a patient. Some physicians like to cardiovert with the device. I don't necessarily recommend it because it can kind of use the device's battery more than it needs to. But it is a possibility. So if you ever do need to shock a rhythm, you press the red button, you'll get this pop-up here that asks you how much energy you'd like to deliver. You can then customize the energy and then deliver the shock. You will still see the capacitor charge across the screen like you see with the normal Abbott device, where you see those asterisks as the capacitor charges, and then a timed shock will be delivered. So, all right. How about this one? This is a CRT question. So first question, what view are we currently in? We've kind of blocked it off here for you. So you're going to have to figure it out on your own, but there's a couple good landmarks that are good clues. And then the second question, which branch are we in?
LAO.
Okay.
Is this an LAO?
So
no, this is not an LAO, Dr. Iseko.
It looks like an
yes.
LAO view.
So this one will be
this is AP.
RAO.
And that branch looks like posterolateral.
Yes, so posterior lateral on that branch. The view is actually
That's the
RAO.
posterolateral.
Yeah. So the view, so we'll answer the first question here. The view is actually an RAO. So normally you'd obviously be able to see it here. Your big clues that you're in RAO right now is the orientation of the spine. So in AP, you would be sitting kind of across the spine. In LAO, you would see generally, because you'd be looking down the barrel of the heart, you would see the right ventricular lead to the left of the spine, and then you'd see the CS lead crossing the spine, indicating that you are in LAO. So this is an RAO, so we're looking down the long axis of the heart. So the heart is actually extended out to here. Another really good indicator here is if the patient, I don't know how many patients you see like this, but if they've had previous cardiothoracic surgery, they have these wires here where they've wired the chest back together. Yeah, exactly. So in AP, the wires would be sitting over the spine, and in LAO, the wires would be to the left of the spine. So this is your RAO view. RAO is really good to look at the heart in the long axis, but it's harder to tell the placement of the LV lead as far as, is it posterior? Is it going more anterior? Things like that. So to answer your question, yes, you had it completely right that this is a posterior lateral. So it would be this vein right here, most likely. It could be a little higher, but I'd say most likely it's the posterior lateral or a lateral vein. I wish we had the LAO view here, but if you look at it here in RAO, the takeoff to the CS is here. We're looking down the barrel. So when you're in RAO view, you're actually looking directly into the os, the CS os, right there, the entrance to the coronary sinus. The coronary sinus then goes down and then more posterior towards the back of the heart, comes out and around. So remember that the more you follow the CS, the more anterior or lateral the structure will be. So your middle cardiac vein will be kind of right there in the septum, but then you'll start to move more of your posterior lateral, your lateral, And then if you go all the way around, you know, you'll end up in the AIV, which is becoming not only anterior, but it's also, I mean, not only is it going to be on the septum, but it'll go more anterior as well. General, sorry?
In this view, is this this view for this schematic, is this an LA or an RAO view in this schematic view?
So this is an RAO view. Yeah, so we're looking down the long axis. This is the same as this one here. Obviously, this is not every heart looks like this, but generally they're a lot bigger and more dilated than even this. But we're looking, we have our spine here to the left. If we had our RV lead, it would be across the spine. Our orientation, our ribs are pointing downwards, this angle. So we know that with the spine this far to the left, we're looking RAO. We're looking down the long axis of the heart. If we were AP, the spine would be more across the heart itself. And then in LAO, the spine would be even more to the right side of the heart. So right now we're looking RAO, we're looking into the entrance of the os, and your CS is going to take this natural kind of check mark shape. And then once again, the deeper you go in the CS, the farther along you go, the more anterior you get. So you don't always want to take the deepest or the farthest option because, oh, you might say, oh, I'm really far in there, I have good stability, but most likely you're going to be more apical than you want to be. You're going to be more anterior than you want to be. So you're not really having good engagement of the tissue electrically. Any other questions there?
Hey, AJ.
Yes, sir.
AJ. Yeah. So if you are to select, if you are left to select between these two veins, which one would you like to select? Because if you left with me, I will go for the one before. That is, I will go for the posterolateral, this one here.
The green one or the purple one?
Or the purple?
No, the purple.
Yeah, that's what I think.
I prefer the purple. The reason why I said so is that one, your CS sheet has to sit a little inside so that it doesn't fall out easily when you are pushing in your leads. So correct. I would prefer this, that purple one, Dr. Iseko.
Okay.
So, but the thing is though, sometimes if you're spoiled for choice, then yeah. But most of the time you don't really have a choice.
Yeah.
Most of the time you don't have a choice. It's like you see one vein that the lead can go in, and then you see a spindly vein. You see one that has like a corkscrew that you can't quite enter.
Yeah.
So if you're lucky enough to say, oh, should I go for this one or you should go for this one, then thank your lucky stars and just go for the first one that you can enter into. This is what I would say.
Okay. But one thing that I like doing double, if it will take me to do double slitting, I prefer it than, what do you think, Ma?
Double slitting you mean putting an inner catheter?
Yes, for you to, if most of the vein around here, most of the vein around
inner catheter here, inner catheter is my main go-to. Like I always carry an inner catheter with me. It's actually quite, I think it's rare that I'm just kind of going in and just going straight for the vein. Usually because of the way the veins come out, usually you end up having to use an inner catheter because of that 90-degree angle, just so that you can kind of get in there. Now, sometimes you have, things go the way that they're supposed to go, and you have a nice canted lead and it catches the tip of the vein and you're able to go through, which is great, but that's less likely. So I think that, at the end of the day, you want one that is the most lateral, posterior lateral or lateral, with the idea that the most lateral part of the heart will have the latest activation. So by pacing it, then you're able to improve cardiac synchrony. Because the idea behind all of this is that you're trying to improve cardiac synchrony. And the best way to do that is by getting the most lateral. So the purple one, it's a lateral vein, yes, but it might end up being, depending on where the tail goes, it might end up being a little bit more anterior. than not. And so, you just kind of have to work things through. There are some times that you have that, middle cardiac vein that ends up having a lateral branch, and that's the one you end up
Correct.
taking. So
Correct.
there's a lot of ways to skin a cat in this sort of
To
situation.
go about it. You are right.
Exactly.
Thank you. AJ, continue.
Perfect. No, I think that's, yeah, sometimes the best vein is the one that you can actually get in. Dr. Joma, so do you typically use an in, or do you use an AL2 or a CSL for cannulation, or do you just like to use like a 90 or an acute for subselecting? How do you typically use your inners?
So I am a creature of habit. I do the same thing all the time. So I put the AL2 in the outer. I use the AL2 to cannulate the CS. Use a woolly wire, go up in, go with the outer over the CS wire, take my AL2 out, and then shoot with, dye in a balloon, figure out my branch. And if I'm going to use an inner, then I will go with the woolly, with the inner back up again, and then I will cannulate with that.
Okay. And you just kind of pick the inner based on the need, the angle of the
Exactly.
inner? Okay.
Exactly. Based off of that. So if it's something that I have to use, like I end up using a 90, I end up using the higher degree most of the time, the 130s, because what ends up happening is that the 90 degree, I want the hook. So basically what ends up happening is with the 130, it's so close that by the time it gets in, it actually hooks onto the os of the vein. And, I'm able to cannulate that really well. The 90s end up straightening out after a little while, and they end up being like a 45, which doesn't really help me. But yeah.
So I will go a deeper discussion into CRT and subselection. I won't. We're going to get some people who are actually, skilled, like Dr. Joma or Dr. Sharif, to talk about this. But the AL2 she was speaking about is going to be an intercatheter that kind of has a shepherd's crook to it. And it's good to kind of point you in the CS. It'll kind of cup the bottom of the atrium and hopefully aim you towards the CS. So you're able to get the right angle of approach and get access to the CS itself. Later on, when she's talking about using a 130 or what an Abbott would call an acute, there's also the 90 option. Typically in the body, it's more rounded than this. The 130 becomes a 90 and the 90 becomes an obtuse, and the obtuse is basically straight because you just have all of this force, this pressure of the lead itself and the vein pushing back. But what she's using is running the larger catheter in and then using this more acute turn to get access to these veins. One thing is we're looking at this in a very two-dimensional model. So it's always good to look at this in LAO as well, because while this looks like it could be a relatively clean takeoff, it could be much more tortuous. We just don't see it in this RAO view. So make sure that you're checking your views, and there's always options of if you're going for a more this one here, say, for example, you go for this vein, it's very long. And if you manage to get all the way down here, just remember the closer to the apex, data shows the outcomes aren't quite as good. So you're wanting to go more basal location. So you may, if you have the ability to pick a lead with wider electrode spacing, for example, St. Jude has a 60 millimeter spacing from tip to prox, which could get you more basal with your later electrodes. But if you use that one here, it's going to be useless because half of the electrodes are going to be sitting here. So it's just things to consider when you're using your product here. Let me get back to my mouse. Okay. How do I clear this? Okay. So this last question, I thought this one's actually pretty fun, and it actually ties back to our conversation that we had last week that some of y'all may have been on the call for. So they went ahead, and we'll go ahead and just use this example here. Using the fluoro image from before, they came in and they did electrical testing. So with Abbott devices, I couldn't tell you about Medtronic, but there's an ability to determine the site of latest activation. And the way they do that is you pace on the RV, and then you sense how long it takes for that electrical pace to be sensed, or the electrical, depolarization to be sensed on the left ventricular lead. And that can give you an idea of how wide your electrical spacing, or how long it takes for the electrical pace to move from the right ventricular lead to make its way all the way through the myocardium to the left ventricular lead. So they went ahead and did some testing. Here are the numbers here. So some really interesting things to point out when you look at P4 to CAN, that's going to be your unipolar. And then you have P4 to ring. As I said last week, I always avoid going to RV ring, not coil. RV coil is fine, but RV ring on a pacing lead is very small, and you have the risk of anodal stem. But you have a high threshold here, and then you have P4 to M2. Remember, we talked last week that there is a chance that you could have anodal stem within the lead itself. So that's a consideration. Why is this one so much lower than the other thresholds here? Well, it could very well be that we're actually not capturing at the fourth electrode, which would be this guy up here. We're actually capturing at the second electrode because the pace is moving from here to here, and due to a nodal stem, we're getting a more apical capture. Whether or not that's a bad thing, that's to be determined based on the orientation of the lead and what options we have, but generally you don't want to anodally capture. So really quick, the questions here before test results. Let's see, what would you say is the optimal cathode for programming? And then based on the actual thresholds, what would you choose as your final threshold or your final vector? So just initially, what do you think is the best one to choose out of these if we ran an electrical activation test? Anybody want to take a shot at it?
I mean, initially you want to think, as you just mentioned there, AJ, you're thinking you want to be basal. So straight away you're thinking maybe P4, M3. They've obviously got the longest QLV time. So that's all obviously in favor of that as well. So yeah, my initial would be either Prox 4, then maybe the mid 3.
Yeah, no, that's exactly right. So both from physical orientation, and then so this is kind of a surrogate of QLV. I love that you mentioned QLV. This is not truly a QLV test, but to your point, it is a surrogate of a QLV test. Sure. So it does its best to replicate it. And QLV is obviously a gold standard that many people will run. So I'm sure we can talk you through that at some point if we ever need to run one with a patient. But exactly, so we have the more basal location. And then also the greatest electrical distance. So not only greatest physical distance possibly, but also electrical distance between the two. So yeah, I would say P4, but then looking at the thresholds, P4 is not ideal. So anyone want to take a shot? Jared, feel free. What you would pick as your final vector? I know there's a lot here, so you can maybe just say what your final cathode would be.
Sure. I mean, naturally, you want to think either anything with the lowest threshold, but sometimes the lowest threshold doesn't necessarily mean the best capture. Because obviously distal tips could be quite apical.
Exactly.
We've got I'm just trying to look through them. Yeah, I mean, you got a mid 2 to mid 4. Again, that's using. Yeah, it's a tricky one. I mean, initially I'm thinking Prox 4 to mid 2. I know it's 1.75, and you probably think, well, that's a volt higher, but usually with LV leads, personally, you don't always have to program the double the output. So you could probably get away with maybe a 2.5 threshold there if this was a chronic lead. But it's obviously an acute lead because it's just been implanted. But yeah, plenty going through my mind.
Yeah, it's a lot. So I will tell you here. So 4 to 2. Based on the fact that your unipolar vector is so much worse than your bipole, this indicates to me that this is actually anodal stem. So it's okay because we're capturing. The way to prove this would be to use a surface EKG and pace from M2 and see if the M2 pacing and also on your EGMs morphologically looks the same as your 4 to 2, right? Because that's a strong indicator then where you're actually evoking any kind of response. You could be capturing it both, but considering the threshold is so high, I would say this is anodal capture. And once again, it's not a bad thing because 2 is actually our best option, I would say as well. And this is what the person who wrote this agreed. 2 is probably our best option, but the threshold is just higher. And if you want to try to pace from the cathode if you can. So yeah, 2 to 4 is what they recommended here. I would never use 2 to ring. Once again, you have anidal stem possibilities. You could be tricked in thinking you're capturing, and you're really capturing in the RV, not even capturing in the LV, and you're pacing this patient into heart failure. So I would avoid the ring like a plague and go to either CAN, or if it's a defibrillator, going to coil. 2 to 4 is fine. You can also go to whatever other options there may be available as well. But yeah, so here, I'll just hold this here so you're able to read it. But no, that would be the best situation, I would say. And then obviously D1, as you mentioned, is getting pretty apical, and data shows that, you know, apical locations is one of the worst places you could be. So feel free as an EP, if you want to jump in, somebody, because once again, we're not electrophysiologists, we're just here to help. So.
I also wanted to mention that the other thing that I look at, you know, having a QLV is great. And the second thing that I look at is actually, even though the papers say that, well, your final QRS doesn't do anything, I honestly don't believe that. I think that the data that we have is old, and nobody's going to do a randomized trial now. But I truly suspect that improvement in your regular EKG actually will portend a better outcome for you. So anyone that gives me the nicest EKG, that's the one that I will take as well. So there are a few things, right? You don't want your battery to die too early, so you're looking for a good threshold. But if, let's say, I had one who had a threshold of 1.75 at 0.5, which is not bad, by the way, but the EKG looks so good, like the QRS is like 90. Oh my goodness, I'm taking that.
Yeah.
No questions asked. So.
One thing before I forget, one thing I forgot to mention, there's no impedance listed here. Impedance also has a massive impact, right? So 4 to CAN or 2 to CAN, for example, could have a much lower impedance, which could actually make a bigger impact on your drain. So, and then, yeah, so I think there's a couple good papers, Trucco, I think they're out of Italy, Trucco et al. And I'm trying to think who else. So some good papers on QRS, like fusion optimized intervals in QRSs. So how narrow your QRS is and association with better outcomes. And I think that we're going to start seeing out of like Abbott and out of Medtronic as they get these adaptive, so SYNC-AV in Abbott and ADAPT-A in Medtronic are these adaptive algorithms that work to kind of get as much fusion between the intrinsic conduction, the RV pace, and the LV pace to gather as much tissue as possible and get the narrowest QRS. So you'd be pacing from here, you'd have the intrinsic working its way down, and you'd be pacing from the LV, and you try to engage as much tissue as possible. I think that would kind of like hold up to what you're arguing is, right, is trying to get the most pretty QRS you can, the narrowest QRS. Now, whether or not LV activation versus narrow QRS, I think that's, you know, I haven't done these studies, I'm not an EP, but I think that I've heard a lot of debate between EPs and about whether or not they want to have more LV activation versus the most narrow QRS possible. But the data shows in general, you know, a pretty QRS is associated with good outcomes. I don't know your thoughts on that though, Dr. Jones.
Oh, I agree. I mean, with the latter part, the LV, the QLV, I think honestly, at the end of the day, of the more modern studies that have been done, the only thing that really showed improvement or really showed improved or predicted your response to a better outcome was really what you had in the beginning, which was, you know, when they looked at echoes showing desynchrony, when they looked at all of that stuff. If your QRS was narrow and you went in and did a BIV, even if the echo showed desynchrony, right, it didn't really show improvement. But if you had somebody who had a problem with their QRS, and so left bundle or severe like non-left bundle, and you somehow improved that, then that promoted or that showed that the patients actually did better post, you know, by the placement. So I think that the EKG, you know, does more, and it's actually, it might be after all this technological stuff, at the end of it, if we come down to the EKG is what's going to show, better improvement. And I have seen patients who, they start off and they are, I have patients who they start off and they have a left bundle, and I give them medication and I optimize them, and their QRS improves by itself. And then I check an echo and their EF has improved. And then there's this one particular guy who, I told, and the reason why I bring him up is because I told him that his EF has improved. He doesn't need an ICD anymore. He got so happy that he had a bunch of celebratory drinks. I guess his cardiomyopathy was as a result of alcohol use. And he came back 3 months later and his QRS was back to being in left bundle. And I checked his echo and his echo was back to being 35%. So it's like, okay, if you have situations, and I'm not the only person that this has happened to, because I was going to write a paper on it and then I realized, no, this is a common phenomenon. But it does go to show you that, hey, this is actually a thing. And, whereas not all left bundles have cardiomyopathy, if you have a cardiomyopathy and a left bundle and you get rid of the left bundle, typically those patients will do better with regards to their EF.
Sorry, I was repeating that in my head. Okay.
Can I ask a question? Just AJ and Dr. Kuru probably jump in as well, just on the medical side. But do you guys in the US use imaging like MR to help you guide LV placement or CS lead placement? Because especially in patients maybe with ischemic cardiomyopathy, looking at tissue viability and making sure that you're actually putting the lead in a place where you're going to generally catch viable tissue. Is there any evidence for that?
No. And I don't know if there's no, at least for us, it's just an added, I typically will do MRI for patients who have non-ischemic cardiomyopathy to figure out diagnosis, but there isn't really any evidence for any imaging to be done prior to. And then unfortunately though, it goes to show you that, sometimes you put it in, you see a lovely vein, and you put it in and the thresholds are like, you don't even have capture at 10. So that tells you that, you're in an area of scar and there's nothing really you can do about it.
Yeah.
Unfortunately. But yeah, that does happen for sure.
I think at WashU, we have used MRI before. This is back in St. Louis, but it was already done. And it's kind of like when you have it for like a VT or something, it's like a good reference, but I don't think they ever did it on their own. They just had it and they used it. So
yeah. No worries. It's certainly not used here in the UK as gold standard, but not at all. But it's just something I've always queried, whether you spend hours and hours sometimes trying to get an LV lead placement, and you put it down and you get there and you go, oh, I've got no capture at 8 volts. You're like, oh. But maybe if you were driven a little bit more by some imaging techniques, that maybe you go, right, this is the area. This is where the area we've got to target, and just make planning the procedure a little bit better. But again, that's cost. It's not cheap to do that, and it's quite not time effective either.
And I think it's also one of those things where, the vast majority of patients, you don't need to do that. So to do that for the 2% of patients that it would be a benefit for is not necessary. And I think that's the reason why it's not recommended.
Cool. Thank you.
So as imaging gets better and cheaper, I mean, that could very well be a viable option too. But yeah. Perfect. I am posting the answers for today's quiz in the group. So if you have any questions, feel free to reference that, reach out to us. Does anyone have anything else? I know we've taken up almost 2 hours of your time, so we appreciate everybody hopping on and listening to us chat.
That's been great, mate. Thank you. Thanks, Dr. Edafe. And everyone.
Thank you very much.
Thank you, sir.
Thank you so much. Yeah.
Thank you, Dr. Edafe, Dr. Iseko. Oh, yes, thank you, everyone.
Yes. AJ, enjoy. Yeah.
Bye.
Thanks, guys. Good night.
Thank you, Dr. Kiro. Appreciate
Dr.
you.
Joma, thank you very much.
Thank you.